Well, good afternoon, everybody. My name is Frank Stichter, Strategic Health Plan Consulting. Very excited today about this webinar for Colorado employers. We've got just a terrific lineup here for this afternoon. We're going to start with SteveKelly, who's co-founder and chairman of Imagine 360. He's a recognized expert in the insurance, employee benefits, and risk management industry, bringing more than 3 decades of experience solving his clients' complex healthcare challenges. He pioneered the concept of reference-based pricing to address the challenges of employers who were burdened with skyrocketing healthcare costs. He has dedicated his career to solving those complex challenges. Steve has been featured in multiple local and national media outlets, including NPR, the New York Times, Newsweek, and Fox Business. Welcome, Steve. We also have Marilyn Bartlett. She is a former state of Montana employee benefits health administrator. And she took the helm of the state of Montana employee benefit plan in late 2014, moving the plan from projected reserves of negative $9 million to $112 million in less than 3 years. That's a positive $112 million. She disrupted the status quo by implementing reference-based pricing, contracting with all Montana hospitals. She currently serves as a senior policy fellow for the National Academy of State Policy, addressing healthcare pricing and policy, and was selected as the number 13 of the world's greatest leaders by Fortune magazine for her work in the healthcare financial arena. And we also have Ted Lavender, who's the founding partner of Lavender Hoffman and Alderman LLC. He's a preeminent legal expert focusing on defending medical malpractice cases. He also represents physicians, hospitals, nurses, psychologists, nursing homes, dentists, pharmacists, chiropractors, and all other types of ancillary medical care providers. He also represents, very importantly, ERISA healthcare plans, their fiduciaries, and plan participants in healthcare reimbursement disputes and litigation. Mr. Lavender is pleased to occasionally to be able to represent patients around the country in hospital billing disputes at no charge to the patients. He is also the attorney who pled the Supreme Court case in Colorado earlier this year. So having said that, and I'll introduce myself near the end, but Steve, why don't you go ahead and take it away?
Thank you, Frank. Good afternoon, everyone.
I'm sorry, just a housekeeping note. If you have questions along the way, please put them in the chat and we'll get to them at the end. Sorry, Steve.
No problem. Thanks. Great to be here. We're going to talk about reference-based pricing. We're going to talk about a few different things, but the concept of reference-based pricing as it happened in 2007 when myself and my partner, Woody Waters, launched this concept. Then you'll hear from Marilyn about a practical application with the state employee workers. And then Ted will talk a little bit about the legal implications, and particularly the case that occurred in Colorado, which was really an interesting insight into how the public and the judiciary see reference-based pricing. So I think you'll get a good cross-section of information here that should be very helpful. What I would like to do is talk about what is reference-based pricing, the good and the bad, what it started back in 2007, how we started with this concept, and how it has evolved both as a tactic to control costs for employers, but also how it's become more of a full health plan concept, at least with our company. And three, why would you do it or why not do it? What does it mean? I'm a business owner. I started several businesses. I have employees that are the key to success with any business. And it means our employees are on reference-based pricing and have been for a number of years. I treated for cancer with reference-based pricing. So I'll try to give you all those different perspectives and not just technical information, because I think ultimately this becomes a business decision. And the question is, what does this mean to my business operation? And what does it mean to my employees, the key cornerstone of any business? So with that, if you can move to the first slide there. So I'm going to talk a little bit about our company. None of this is to I'm not trying to sell you in our company. We have 6 or 7 legitimate competitors out there. I'd be happy to name some of them if you would like. But the best way for me to tell this story is to talk about our company and our evolution. And we started this idea. So as you follow our company, you follow the process of reference-based pricing as well. Current state, Imagine 360 and the subsidiary ELAP have 625 clients using reference-based pricing. The payoff for those clients is they typically save between 15 and 30% versus a traditional Blue Cross, United, Cigna, Aetna type plan. A big concern for any employer is, if I do this, what does it mean to my employees? What does it mean to my workforce? We always cite that we have a 78 net promoter score, which means that a high number of our clients would refer us to others and are pleased with our process and our company and our services. By comparison, most of the major insurance companies are somewhere in the 0 to 5 to 10 range for net promoter score. Point there being, given the longevity and giving these the savings and the net promoter score, it is a concept that an employer can use and use effectively, and it's a positive for the company. 98% member satisfaction score. So it's not a new concept. It's not something you have to grit your teeth and endure and just take the bruises. It can work very, very effectively and does often for our clients. Next slide, please. So here's a little bit about our company, how it started, how we got to where we are. And as I say, we have competitors, most of them. The first one came in around 2010, and then over the years, more have come into the marketplace. But in 2007, we were working with a manufacturer in Valdosta, Georgia. 2007 was not a great economic time. This company manufactured home building parts, supplies for new home building, new home construction. There was not a lot of that going on in 2007. So they had an acute need. The woman that ran that company had an acute need to get her arms around cost. And the employee benefit plan was continuing to spiral upward as it does to this day for many employers. And we were working with them, and we developed an idea that our conviction is the traditional PPO process that is being used by Aetna, Cigna, United, Blue Cross was not serving their needs, was not accomplishing their goals. So we worked out, we'd handled a few files with them, we had some discussions with them, and we worked out a process whereby we would begin to pay medical providers on a formulaic basis with reference points in the plan document, their self-insured plan. And that's what we did effective November 1st, 2007. That was the first case. And I'll tell you a little bit more about exactly what that looked like in a minute, but that was our first group. Over the next few years, we brought on a couple dozen other employers who were looking to get their arms around this cost of plan issue, and began to kind of sharpen our sword a bit and develop the model that continues to evolve to this day. We do contract with health systems. Typically, a Blue Cross United Cigna plan relies on a network of providers. We have a different approach, which I'll go into in a minute. But we do contract selectively with high quality health providers around the country. And Imagine Health was a company doing that very effectively, developing custom networks for companies like Home Depot. So we merged with them in 2018 and brought that contracting dimension to the table. Historically, it had been hospital services, but in 2019, we began to work on the physician side as well. We were providing one service, this reference-based pricing, the repricing of claims, but we realized what the market was calling for was a more seamless, integrated whole health plan approach. So in 2020, we reached out to 2 of our major trading partners, came together with them, and formed what is now known as Imagine 360. And that's the current format by which we trade today. And it's really a full health plan concept. It's not just one service we provide on a certain segment of claims. It's a full health plan concept. So you can buy a product today in the reference-based pricing marketplace that is a full health plan and can be a total replacement for a Blue Cross Cigna Aetna plan. It wasn't that way back in 2007. It is that way today. Next slide, please. So I said earlier, the PPO model, the traditional benefit plan, isn't working. And why isn't it working? Uh, it doesn't contain cost. We would argue it also doesn't advance quality, but the major issue, the issue that we think is critical in healthcare and across the country these days are that this middle slide. Employees are shouldering additional levels of costs that were unheard of a decade ago. More and more employers become frustrated with the rising costs, or the economics of their business give them no alternative. So what they do is they push costs down to the workforce in the form of higher deductibles and co-pays. That's not just a plan design issue. We would argue it's a quality of life issue for many of these employees, and that they are now in a position where, as you look at the slide all the way on the right, or the issue on the right, families, people are skipping medical care. They're not filling prescriptions because they simply don't, economically, they can't do it anymore. Of course, that causes non-compliance for conditions like diabetes and other chronic conditions. It's sort of like a dog chasing our tail. We keep pushing more costs down because we're trying to save money. The conditions worsen, so we spend more money. And as I say, it's really a quality of life issue for the workforce. So our contention is that there's a better way to do this than the traditional plans. It just requires a little bit more assertiveness on the part of the employer, and that's what reference-based pricing brings to the table. Next slide, please. So what is actually happening? What do I actually mean by reference-based pricing? The simplest way to think about this is, historically and to an overwhelming degree now, most employer-based health plans, when they use a traditional network through any one of the carriers, what you're buying is access to a panel of physicians at hospitals, a contracted network of medical providers. And the traditional mechanism by which medical providers offer their services to these networks is a percentage off charges. So they provide a bill to your health plan, say it's an MRI or Tylenol or gauze pads or a diabetes test strip, and they just name the price. So they can charge $1.50 for a Tylenol, which you can get for 15 cents in CVS, and then offer a quote unquote discount of 50%. That's a fairly typical scenario that is repeated literally millions of times every day between medical providers and health plans. So what's happening, the takeaway here is they just mark up the bill to whatever limit, to whatever amount they want. It has no rational relationship to the cost to provide the service or the cost of the item itself. And then we pay a discount off of that. So you would never buy a car on that basis. I mean, if you went out, if your son or daughter came home and said, I'm going to buy a car, and guess what? I got great news. I got a 50% discount. Of course, your first question will be, off of what? And that just doesn't work. You would be very worried about a person buying a car or any item with that level of sophistication. But unfortunately, most American employers are buying healthcare under that basis. So the medical provider determines a price that's contained in a charge master somewhere. It has no rational relationship at all to the actual cost of the item or the service, and then we pay a discount off of that. That is the status quo, and that's what reference-based pricing at its most basic changes. We work from the bottom up, and I'll show you in a second how that works. So next slide, please. And that's a key point. So what does this, all of this discounting off of charges, what does that get us? If you look at the RAND recently did a report in May of 2022. They've done several over the years, but the most recent one took a look at every state and said, what are commercial health plans? What are the blue type plans, the networks that you guys are using typically? What are they paying relative to Medicare? Medicare is the largest payer of healthcare services in the world. They do an exhaustive data study on an annual basis of every hospital, and they determine reimbursement based on the hospital's own annually submitted data. So a good check is to say, what are commercial health plans paying relative to Medicare? In West Virginia, 3.17 times that amount. So you can see all across the country, this is the case, that health plans are paying vast multiples of Medicare. And why is that? Now, the hospitals claim that Medicare underpays them. We could argue with that quite a bit, but many hospitals are profitable on Medicare reimbursements. The better run hospitals are all the time. Hospitals and insurance companies jump all over each other to participate in Medicare Advantage plans. So I don't quite buy that they're losing money on Medicare, but even if you did, they often claim you're losing 5 to 7%, but they're getting paid 3.2 times as much. That math doesn't work in our mind, and that we feel that is why the PPO process poorly serves the employer community. Next slide. So here's what it looks like. In Denver, Colorado, we looked at a few different hospitals, Denver Health, St. Joseph's Hospital, Rose Medical Center, and looked at the average bill charge for a CT scan. Now, CT scan is a really basic procedure. We're not talking about brain surgery here. This is a very simple diagnostic scan. Rose Medical Center charges $94.05, but why wouldn't they? If you think about it, if their contract with most of the major payers are based on a discount off of what they charge more. It's not rocket science. So if you are getting a percentage discount, 50%, you can see just across the graph there a little bit, you could be paying $4,700 for a rather simple service. The cost, as reported by these hospitals to Medicare in 2021, Denver Health 108, St. Joseph's Hospital 135, Rose Medical Center 136, is a small fraction of what they're charging. So what we do and what reference-based pricing does, we go to those two columns in the middle. We're using what their reported costs are and what Medicare pays. And we will pay 12% above their costs, or Medicare plus 20%, the higher of those two metrics. That's typically the way we go after medical pricing. So our contention would be that we're using their latest data submitted within the last 12 months. It's not data that we compile. It's not a regional average. It's that own hospitals specific data. And that's the cost side. And then we compare that to a Medicare payment plus 20%. So we feel by any metric or by any consideration, this is a fair and equitable way. There's no perfect way to price medical services in America, but I would ask you, do you think those two columns, average cost of Medicare pays, are more equitable than charging $9,405 for something you report as costing you $136 to perform? So that's the basis of reference-based pricing. We move away from bill charges, we move into we come, instead of coming from the top down, we come from the bottom up and build a reimbursement. Next slide. So I'd like to think we were brilliant and we thought this up, but actually some large and very reputable organizations come to the same conclusion. CalPERS, which is the public employee retirement system in California, purchases huge amounts of care for active and retired California employees, state employees. They took a look at what they were paying. This is a very large buyer with significant clout and sophistication, you would think. And they looked at between 2008, 2010, they were paying between $17,000, $115,000 for the hospital portion of hip and knee replacements. So that leads me to the question, what is the value of a network that you pay an access fee to get that kind of disparity of cost? So they said, we can't continue to do that. They said, we have to pay a reasonable amount. So they have the ability, given their size and scale, they said, we pay $30,000 going forward for those services to all hospitals. And the hospitals that will accept that step forward, the ones that don't step back, workforce, you just have to realize we can't continue to treat a $30,000 expenditure like it's $115,000, or it's going to end up being less compensation for state employees at some point in time. So that's what they did, saved a ton of money. And that was an example of a large buyer using their clout. But we believe that smaller employers can use that effectively as well. So next slide, please. So here we go. So this is what it actually looks like. And this is the point I was trying to make before. We come from the top down. So the charge master price is $5,000. If you get a 50% discount, you're at $2,500. It's not real complicated. If you take the actual cost of the same hospital, which might be $250 for the same procedure, Medicare pays the hospital $280. we're going to pay we're going to increase Medicare by 20%, or we're going to add 12% to their actual cost. We'll pay the higher of those two. So in this example, we paid $336. We're very confident that that covered the hospital's cost. And Ted will talk a little bit later about when problems occur between the hospital and the plan, and in the highly unusual circumstance, infrequent circumstance where that gets litigated, we'll see how the court responded to that. Next slide, please. So why would you do this? This approach can typically save an employer 15 to 30% in year one. So that's significantly deeper discount than you get with a typical PPO plan. It allows you to treat medical expenses the same way you treat other business expenses. We think this is just allowing you to apply the same business acumen you apply in other areas of your enterprise to healthcare. What has happened, I think, over the years is we have just abdicated our roles as employers. I'm speaking about myself now, and I allowed an insurance company to do this for us to no good end. So this approach that I just described, when projected across an entire body of claims for an employer-based health plan for a year, will generate typically 15 to 30% savings. If you're paying, $10 million a year for healthcare for your workforce, that's a significant drop to the bottom line. And oftentimes we can use those monies to reduce copays and deductibles, which is what we think is a win-win situation for all involved. Next slide. So there are challenges, and we think this is where we as a company have differentiated ourselves from our competitors. You need to educate your workforce as to how the plan works. Our experience tells us that when an employer takes the time and works with us to educate the workforce, this works very well. We renew about 88 to 90% of our business every year, which is exceptionally high in our industry where people jump from company to company. So we're very confident that you need, with proper member education, this works extremely well. Another challenge is poor member advocacy. You can't, I would argue, you can't do this in a traditional Aetna Blue Cross United plan. You can't just turn people loose in the health system without support and guidance. And we as a company place a lot of emphasis on educating our staff to be able to answer the questions, to be able to guide the employees, to provide the support they need in the case of a hospital challenging our payment. And we'll get into that a little bit more, and Ted will dive into that a little bit more in his segment. And aggressive providers. There are some providers across the country that don't like reference-based pricing, flat out. So we have to be prepared to negotiate with them when necessary. We will contract with them if the situation avails itself. But basically, we're coming from a place here, and this is the contentiousness of reference-based pricing, where we're saying we as employers have a right to pay a rational amount for services. More than a right to pay, we have an obligation, we believe, to pay a fair amount for services, and not to just wring our hands and then push costs down to the workforce if the costs become prohibitive after a certain point in time. Next slide, please. So the major rub with reference-based pricing is why. The question might be, why doesn't everybody do this? Why doesn't everybody? Who doesn't want to save 15 to 30% on their healthcare costs? The major challenge to reference-based pricing is balance billing. And that situation occurs where, if we go back to the example of the CT scan, hospital bills $5,000, we pay $350, which we feel adequately covers the hospital's cost. And the hospital says, well, then I'm going to balance bill your plan member for the amounts over what you guys paid. It happens. It definitely happens. It happens in a relatively small percentage of the overall claims. It's less than 10%, different parts of the country, different hospitals. And on the hospital portion I'm talking about, on the physician side, it's significantly lower, but balance billing does occur. But I think one thing we have to, before we discuss balance billing, you have to consider that in the PPO world, balance billing occurs anyhow. Employees are receiving balance bills for emergency care, for intentional out-of-network situations where you go to a doctor who's not in a network, or even if you have an operation in the hospital, the anesthesiologists are out of network, which happens often. So balance billing is a part of the healthcare landscape in America right now. That's a fact. Among PPO plans, traditional Blue Cross, United, Cigna, Aetna plans, and it happens in reference-based pricing as well. We have a well-developed and intensive process whereby we support the plan member the minute they receive a balance bill. Next slide, please. So all that a member has to do if they do receive a balance bill is take a picture with their phone, get it over to us, and we have a member service advocate that will work through the process with them. There are times when we negotiate the claim to settlement with the hospital. There are times when we challenge the hospital's payments. Oftentimes we find the bills are inaccurate. There's a whole process that has developed from 2007 to present day, where we use a variety of options to work through any problems that occur on the balance billing front. And this just kind of walks you through the process. Our experience is that employees are very grateful to have someone in their corner when this occurs. Traditional plans, they don't have them. And by the way, if you have a $5,000 deductible, most employees at $15, $20 an hour, $10 to $20 an hour employees with a significant deductible like that, they're being balance billed on a regular basis just for their routine care. So we found that by assigning a member service advocate to any kind of problems, it works extremely well. If a provider takes a more militant approach, we use full legal support, and that's what Ted's going to talk about. He has worked with us since day one, back from that first group in Valdosta, Georgia in 2007. Ted Lavender has worked with us through the whole process. Next slide. So if you want to consider this, and we would love to talk to you about it, Frank is one of our better brokers and has a solid background in reference-based pricing. We'd sit down with you and take a look at what would this mean for your company. We can give you a pretty good idea of what it would mean economically. And then if you're looking at us or others, you want to make sure that there is a member navigation, education, and client support. You don't just go into this casually. You need to be sure you're educating yourself and your workforce. Make sure there is a team in place for balance bill resolution if these do occur. And even now, I would recommend, if you have a traditional PPO plan, do that as well. But make sure your people are supported in the healthcare arena because many American workers are totally alone. Make sure that your that your reference-based pricing provider can do direct contracting with the local health system. You may want to just, as an employer, contract with this provider group here or this health system there, and we can do that. We can help you with that. We have thousands of contracts with hospitals around the country, but we only enter into contracts within the best economic and business interest of our clients, just like you would in any other area of your enterprise. We don't enter into contracts that aren't good for our people. Make sure that we reprice and audit all claims. You're only paying for services that are actually performed, and make sure or look into savings guarantees. If you're good at this, as we are, we're confident we are, we should be willing to put our money where our mouth is in terms of guaranteeing that we can deliver on the objectives that we state for your company. So next slide. So that's it for me. I hope that gives you a basic idea. The takeaways would be, you can take a different approach to healthcare. You can take a different look than a traditional Blue Cross, United, Cigna, Aetna arena. It takes a little bit of proactivity on your part, but it is doable. There are now thousands of employers that are doing this successfully, references you can check with. So we would love to talk to you about that, or even just have a conversation. If there's more you'd like to know about this, we'd love to continue the conversation. So with that, I will turn it over to Marilyn.
Thank you very much, Steve. That great presentation, and it's so good to see all the things you're doing now. I was fortunate enough to meet